Welcome. My name is Dr. Victoria Pellick, and I'm a neurologist and professor of neurology and ophthalmology at the University of Colorado School of Medicine. I direct the Colorado PCA Support Program along with Ms. Jerry Lusk, who is our administrative director. And you can find more resources and information about PCA at our web pages, and stay tuned for an updated website coming soon. But the one noted here at the address is still active. Today, I'm going to be speaking about the drug aducanumab, which will be marketed as Aduhelm, and it was recently approved by the FDA under an accelerated approval pathway to treat Alzheimer's disease. It is my hope that this webinar will serve as a resource for you, and you will be able to access it in the future at www.coloradopcasupport.org. And we'll also send a link to those who registered today. So let's get started. First, I want to start with some conflict of interest statements. I am a patient advocacy committee member of the Alzheimer's Association Longitudinal Early Onset Alzheimer's Disease Study. I do not have any financial connections to Biogen, the makers of Aduhelm, but I will be a potential study site PI for the phase 4 study of Aduhelm here at CU. And you should know that CU Alzheimer's and Cognition Center is a site for ongoing clinical trials of aducanumab and for trials in the past. So the questions I'm going to address today include: what is posterior cortical atrophy syndrome? And what is the biology of Alzheimer's disease? Then we'll review Aduhelm. I'll review what it is, what are the potential side effects, who might benefit, and why is the approval by the FDA so controversial? And at the end, I'll address the questions that were put forth during the registration process. So first, we should all recognize that the most common disease that causes posterior cortical atrophy is Alzheimer's disease. And this truly is the reason we'll be talking about Aduhelm today. And keep in mind that Alzheimer's disease can cause many syndromes. And these syndromes are often named and recognized for the first set of symptoms that occur if they are other than memory. So typical Alzheimer's disease starts with a loss of memory. For posterior cortical atrophy syndrome due to Alzheimer's disease, symptoms start usually with loss of visual brain functions, which are in the posterior part of the brain. And then for a syndrome called primary progressive aphasia, symptoms start with loss of words and loss of language. And then for the behavioral variant syndrome due to Alzheimer's disease, symptoms start with a change in personality or behavior. Thus, there are many syndromes associated with Alzheimer's disease, and posterior cortical atrophy syndrome is really just one of those. So let's take a closer look at the syndrome of posterior cortical atrophy. The word posterior refers to the back part of the brain, as circled here in this cartoon, and the word cortical refers to the brain's cortex, which is that wrinkly part of the brain, shown again in this cartoon with different cortical regions represented by different colors. And the word atrophy refers to the loss of brain cells that occurs and results in symptoms. So one might ask, well, why do these cells die? And the answer to this is unknown, but it really is the holy grail of unlocking Alzheimer's disease. We do know that there is abnormal buildup of brain proteins that appear before the death of cortical cells, and these proteins are called amyloid and tau, which I'll speak of in a few moments. But first, let's look at the diagnostic criteria for PCA, which was published in 2017 by Crutch and colleagues, and I was privileged to be a part of that group. And to the right shows the PCA diagnostic criteria in the form of a table that really outlines first the clinical features that must be present, and then the type of impairment that must be present. And these impairments result from atrophy of the posterior cortex. Then the type of brain imaging findings that should support a diagnosis of PCA. And finally, the criteria do specify that non-posterior functions must be relatively spared, meaning either unaffected or affected to a lesser degree initially than the core cognitive features found in row 2 of this table. And then finally, other causes or conditions really have to be excluded. So this is our clinical guideline to diagnosing PCA. And instead of spending a great deal of time on these details, I really wish to present this to help you understand that we have a clinical guide for really deciding whether somebody has PCA syndrome. But we also have ways to find out while the person is living whether the underlying cause of PCA is Alzheimer's disease. We usually do this through a spinal tap or through research tools such as a PET amyloid imaging study or a PET tau imaging study, or both of those together. Really, amyloid, however, is the key to making the diagnosis, the underlying diagnosis of Alzheimer's disease. And we'll get to that a little bit later. And in fact, we're first going to talk about what is the biology of Alzheimer's disease, and we're going to use PCA as an example. And as I noted, PCA is most commonly due to Alzheimer's disease, where there is an abnormal accumulation of brain proteins called amyloid and tau. And as a reminder, this is not related or impacted by the protein you eat, for instance. These are not proteins that you find in your diet. They're brain proteins. And I'm going to show you an animation and describe how the abnormal proteins build up. So first, amyloid builds up throughout the brain, and this buildup is actually slow, over 10 to 20 years. And then tau begins to build slowly here in blue before the amyloid accumulation completely stops. But eventually, amyloid stops building up while tau keeps accumulating, and then atrophy and symptoms really start to set in. And so the key point to make here is that the amyloid nearly fully accumulates by the time a person is having symptoms and during the mild cognitive impairment stage or the mild dementia stage. And I'm going to show that to you here graphically. I want to take the time to explain this so that we know about the abnormal accumulation of amyloid in the timing of symptoms before we start to talk about how Aduhelm works. So to orient you, on the horizontal line, or the x-axis here, you can see the progression of the symptom stage or the clinical disease stage, while on the vertical or y-axis, you can see a change in the marker that one looks at. So for instance, the accumulation of amyloid represented by the red line, neuronal injury change shown by the blue line, and cognitive symptoms represented by the green line. And now I'm going to mark the time where amyloid has essentially fully accumulated. You can see it here at this yellow line, which occurs by the early dementia stage and at the end of the MCI stage. And MCI stands for mild cognitive impairment. So just to emphasize again, and in summary, by the time a person has symptoms, amyloid has nearly fully accumulated and neuronal injury is really starting to take off. So those are important features of amyloid accumulation and important to understand as we start to talk about what is Aduhelm. So now we'll move forward. So Aduhelm is an antibody. It's made in the lab, and it was designed to bind to abnormal aggregated forms of amyloid or beta amyloid. Here you see how amyloid can start as an original small protein, and then in the case of Alzheimer's disease, it can abnormally aggregate into plaques and impair a cell's ability to send out important signals. Now, if we think about why nerve cells die, we unfortunately still don't know for sure. One theory is that amyloid results in the buildup of the protein tau, and that tau causes the cells to die. Another theory is that cell death is due to toxic forms of amyloid. And then finally is the theory that it's really a combination of amyloid and tau that can create the correct atmosphere for brain cell death. So where does Aduhelm fit into all of this? Well, it removes amyloid and does so either via bloodstream or by recruitment of immune cells to ingest it and then get rid of the amyloid. So here in blue, you see the Aduhelm antibodies and the amyloid that it binds to, and then with more and more exposure of the drug, the amyloid is eventually removed. So that brings us to the results of the Aduhelm clinical trials, in which people with mild Alzheimer's disease were given monthly infusions. And Biogen, the manufacturer, asked two main questions: does Aduhelm remove amyloid? And does Aduhelm improve cognition and function? And to answer that, Biogen compared those who received placebo, meaning no drug, to those who received Aduhelm. And remember, to be in the studies, you had to have only mild impairment. So the first question, the answer to whether Aduhelm removes amyloid is yes, it does remove amyloid. And I'm going to demonstrate this by showing you data presented by Biogen with amyloid PET scans. So using amyloid PET scan images of the brain for 4 different patients who were in the study. These all shown here are the baseline or pre-drug, so before drug was given, scans. Wherever you see yellow and the red, this is where amyloid exists. And every one of these 4 participants in these drug studies had above normal or abnormal accumulation of amyloid, and so they all had Alzheimer's disease. So let's now see 1 year later what their scans look like for each of these 4 participants. At the top, you see for participant 1, 1 year later, they received placebo or no drug. And then you see patient 2 and patient 3 received low doses of either 3 milligrams per kilogram or 6 milligrams per kilogram for participant 2 and 3, respectively. And then for participant 4 received 10 milligrams per kilogram. And you can see how the yellow and the red really decrease in everyone getting the drug, but not the person labeled as number 1 who received placebo. Their scan for the placebo treated patient number 1 did not show a decrease in amyloid. And this was done for hundreds of patients involved in the study. And so it was concluded, and at this point, I think all experts really agree that the drug did engage the target and it did remove amyloid. Now, what about cognition and function results? So there's a couple of things we need to discuss before we review in depth the results. First, there were 2 main phase 3 studies that were done, and both were identical studies. And in both of those studies, all participants, whether they received the drug or placebo, declined. They declined in their cognition and in their function. If you look at those participants who received high dose versus those who received placebo, again, placebo is the group that did not receive the drug. The first study, or study 1, showed that the drug slowed decline versus placebo, while study 2 actually didn't show any difference between high dose and placebo. And for the low dose versus placebo, neither study showed any change. So when you look at high dose, only study 1 showed a difference and study 2 didn't. And so let's look at that more in a graphic form, so a more visual form, just for high dose right now, and to provide to you a few more details. So study 1 is over here on the left, and I represented those who received Aduhelm as a red line and those who received placebo as a black line. And you can see over time, and it's important to note, that both groups declined in cognition and function, but at the end of the study, those receiving Aduhelm declined more slowly for that one study, study 1. And the results showed approximately 22% slower decline in cognition and 40% slower decline in function for those taking Aduhelm. Meanwhile, in study 2, there were no differences, and this is all with the high dose, no differences between the 2 groups. Both groups declined really at the same pace. So you have 2 studies showing 2 different results. And remember, both of these studies were identical. And just to remind everyone, for the low dose Aduhelm, there was no difference between those getting the drug and those not getting the drug. So in the end, we'll mention that the approval has been made for the high dose. So next, we're going to talk about what are the potential side effects for Aduhelm and who might benefit. So we're going to kind of go beyond the results and talk about side effects and who would be potentially benefiting from this drug. The most important side effect is a condition called amyloid-related imaging abnormalities, or ARIA for short. And on the left, if you can see this, you'll notice brain swelling that's represented by the slightly lighter color of the brain where it should not be found. And the red arrows are pointing to that. And that's due to brain swelling or brain edema. In the right image is an MRI scan of the brain that where the arrow is pointing, you might see these dark corkscrew looking changes. And this represents small bleeding regions. So oftentimes the image on the right, when we see that, is referred to as ARIA with hemorrhages, and the imaging on the left with the swelling is referred to as ARIA with edema, or sometimes people will shorten this as ARIA-E for the left image finding and ARIA-H for the right image finding. So before we discuss what are the symptoms of ARIA, let's look at its frequency in the Aduhelm study. So how often did ARIA occur? For those taking high dose for 78 weeks, the study had about 35% of patients having ARIA noted on imaging, and 65% never experienced any ARIA noted on imaging. And so then of those who had ARIA, how many had symptoms and what were the symptoms? So about 35% of the total number had ARIA symptoms, had ARIA to begin with, pardon me. So 35% of all people receiving high dose had in the studies had ARIA, while only a third had symptoms. And this included headache, nausea and vomiting, confusion, tremor, and then balance and gait problems. Now, of course, there are more than symptoms just due to ARIA. There are other symptoms that were less severe for the high dose group, and 9% from study 1 and 12% from the other study had to stop treatment due to other adverse events. Whereas in the placebo, remember that's the group that doesn't receive the drug, and they didn't know they weren't receiving the drug, and their doctors didn't know either. But about 3% from study 1 and 5% from study 2 had to stop for adverse events. So beyond ARIA, there are other adverse events that require somebody to stop the drug. So what if ARIA occurred? First, it's important to know is that it was reversible during the study when careful monitoring was occurring. And it's important to note that the drug was stopped or the dose lowered, and then before the drug was restarted, symptoms resolved or imaging changes resolved. They had to go away before starting the drug. And in some people, they were too severe to restart the drug. But all of this was done with very, very careful monitoring during the study. So who might benefit? Well, if Aduhelm helps cognition and function, and remember, we had 2 studies with different results, then those who might benefit are only thought to be those with mild cognitive impairment due to Alzheimer's or mild dementia due to Alzheimer's, because those are the group that was in the study. And just again, to try to bring back this slide and this graph to show that the drug has only been studied in people with this very mild category. And this group is really those that are falling in the timeline in the yellow hatched area, those with mild cognitive impairment or MCI and the early stages of dementia. So finally, this brings us to why the approval by the FDA was so controversial. So many of you likely have seen these news articles stating that the FDA approved the drug despite fierce debate over whether it works, or there are doubts whether it slows progression of memory-robbing disease, and also that 3 advisors to the FDA resigned due to the approval of this drug, which is really all unprecedented. So let's unravel this just a bit. So here are the main reasons for the controversy. First, recall that 1 study was positive and 1 study was negative in regards to impact on cognition and function. And usually the FDA does not approve a drug on the basis of 1 positive, 1 negative study, and typically requires 2 positive studies. And note that because of the findings, an FDA advisory committee voted pre-approval on whether approval should take place. And this is how they voted. 1 of 11 said yes, 8 said no, and 2 felt uncertain. But the FDA went ahead and approved this in the accelerated approval pathway, and that approval is based on a surrogate marker, which they used as the amyloid removal, which was all agreed upon by really universally that the drug really does remove amyloid. And then they require now Biogen to complete a phase 4 study. However, concerns exist that regard the uncertainty that amyloid removal will ultimately always lead to a better course for cognition and function. There's a lot of uncertainty about that. And the other concern is that the FDA gave Biogen 9 years to conduct this phase 4 study, which is quite a long time. Next, as part of the controversy, the FDA did label the drug approved for Alzheimer's disease, and they didn't mention amyloid, and there was no mention of the level of impairment. And then finally, Biogen has priced the drug at $56,000 per year, which is quite a hefty sum. And some assessments have shown that cost effectiveness of the drug does not reach really beyond $6,000 to $8,000 or so per year. So final notes before I start answering questions is eventually we will be able to learn a lot more over the coming several months because right now it's unclear whether Medicare or Medicaid or insurers will pay for Aduhelm yet. And CSF is currently the only way outside of a research amyloid PET scan to be tested for amyloid reliably. Blood tests, however, are in the later stages and they're being widely validated. So the hopes are that we would have another test, like a simple blood test, to help us determine whether somebody has amyloid in the brain. And then in terms of guidelines, the label by the FDA really provided little to no guidelines for its use, other than recommending the dosing and the dosing schedule and the monitoring with MRI scans after the 7th and 12th infusion. And otherwise, there was very little to help guide people on criteria for giving this drug and for how long the drug should be given. So a lot of unknowns still. Eventually, guidelines will be and begin to be agreed upon by experts, and we at the CU Alzheimer's and Cognition Center are writing our own local guidelines now. And I'll mention that a bit more when I review all of the questions. So I'll review those questions that were sent during registration, and I do think we're going to have some time to open it up so that others may be able to ask questions, especially based on what they heard here thus far. So one of the questions we received is the amyloid plaque causative? And the simple answer to that is this is debated. The cause of symptoms we know is brain atrophy, but the reason for the atrophy is debated. We do not know if it is the interaction between amyloid and tau, if it is certain species of the amyloid protein that cause death to the brain cells, or if it is tau even alone once it accumulates that causes brain atrophy. We do know that you have to have both amyloid and tau to be diagnosed with Alzheimer's disease. And in particular, amyloid has to be present. You cannot just have tau. You must have at least amyloid. So there are a lot of lessons to be learned, certainly not only from the trials of Aduhelm, but a lot more to be learned and understood about why atrophy occurs, what causes ultimately the death of these cells. So this is still debated. And another question that we had from several registrants is, if you have PCA, are you eligible for Aduhelm? And the simple answer is yes, as long as the guidelines that will eventually be written follow the sort of the rules of entry that were in place for the clinical trials, which is mild cognitive impairment or mild dementia plus amyloid, then people who meet those criteria will be eligible for Aduhelm. So essentially, if you have Alzheimer's disease, you're eligible, and people with PCA have Alzheimer's disease. There are going to be some criteria that eliminate eligibility, but right now, most centers will likely be including people who have mild cognitive impairment due to Alzheimer's, mild dementia due to Alzheimer's, and who have evidence of amyloid. So next, do we know if Aduhelm will work for PCA? We had several questions about that. And no, we don't know this specifically. Alzheimer's disease syndromes were not identified in the study. When PCA is due to Alzheimer's, however, we expect similar response to those that were in the study. So these labels, these syndromes, were not put upon people who entered into the study. Again, they had mild cognitive impairment due to Alzheimer's, or they had mild dementia due to Alzheimer's. The type of syndrome they had was not identified or reported. So one question came in is, would I prescribe for any level of severity? The answer to that is no. I would not prescribe beyond mild impairment. And removing amyloid in the later stages with other agents have failed to have an impact on cognition and function. This has been shown with other agents that remove amyloid in the past. And specifically, the only drug we have approved to remove amyloid now is Aduhelm, and it was only studied in mild impairment. So I would not prescribe this for any level of severity, only mild. And another very good question is, are you advocating for inclusion of PCA in clinical trials? The answer to that is yes. In fact, a main goal for the CU PCA program is to advocate for inclusion of PCA in clinical trials, and we're working hard with step one, which is creating appropriate measures to follow people in clinical trials who have PCA, because certain measures may not be very useful to follow. So if you're following memory, and memory is relatively preserved and stays relatively stable in the first couple of years, it'll be very difficult to know if whatever treatment we're giving is making a big difference for PCA. So instead, we need specific measures for people with PCA. And that's really one of our working projects that are ongoing right now here at CU, as well as across the country and in collaborations internationally as well. So does Aduhelm improve mobility? This was not reported, but I do want to remind everyone that, again, that these were just mild stages. And so mobility and falls, although they weren't reported, it was very unlikely that people included had mobility problems due to Alzheimer's disease. Another important question is, how do we get Aduhelm? And the simple answer to this, which is an incomplete answer though, is likely through major centers, major Alzheimer's centers, major academic centers. And we should remind everyone that there is a lot of infrastructure necessary to be able to give people infusions monthly at an infusion center and monitor them carefully, take calls to answer questions about potential side effects. And right now, a big question mark is looming and pending. What is the Centers for Medicare and Medicaid Services going to do? And what are the insurers going to do about paying for this drug? Obviously, not a lot of people have disposable income at $56,000 per year, as well as paying for multiple MRI scans and paying for the care, the clinical care that one will need, as well as paying the infusion costs. So a lot is riding and pending on the CMS and insurers' decisions. So again, many questions about who is eligible. And to remind everyone, the FDA label essentially said Alzheimer's disease. And this is going to depend a lot on the guidelines eligibility, because most are looking towards limiting who gets this drug to those who were eligible for treatment in the trial, since those are the data that we have. And we know that more severe patients with other drugs did not show benefits, even though amyloid was removed. But guidelines will for sure be coming likely nationally and locally. And limitations from Medicare and Medicaid and insurers will likely develop over time and really provide a guideline to its best medical use at this juncture. And another really great question was, how are we going to monitor for ARIA? Well, the FDA has mentioned there are labels, or the FDA label does have indications. And first, an MRI within 1 year of start so that you know where somebody's baseline is and if they're eligible. And then after the 7th and 12th infusion is what is currently being recommended. Guidelines might increase the monitoring. We'll have to wait and see. So thank you so much for joining us. The presentation will be on our PCA support web pages soon. And now we do have some time to open it up and ask further questions. So again, I thank you very much for your attention, and I look forward to providing for you as much support as I can along these months. And please turn to our web pages for more information. Thank you.